Good afternoon, and welcome to our quarterly webcast for the Methodist DeBakey Cardiovascular Journal. I'm Quiñones, the editor-in-chief of the journal, and I'm joined today by Dr. Dipan J, who was the guest editor for the current issue, which was dedicated to cardiac imaging, a very, very important part of all of us practicing cardiologists. That issue came out with a lot of wonderful articles. We really encourage you all to look at it online, or if you have received it by print, enjoy reading it at home. As I mentioned, that there's a slide that hopefully will be coming on soon that is telling you, all of you, how you can subscribe to our journal. Over the next few months, we're going to be moving more and more towards an online publication. But those of you who still want to receive the print version, you can do so free by basically subscribing. So if you see that slides in the screen, all you have to do is take a picture or use your phone camera for the barcode, and that will take you straight to the page where you can create your own subscription, and then you can also continue to receive a print version of the journal. As we are doing our webcast, there's going to be a lot of interesting material presented. You may have some questions you want to send us. So if you want to do so, all you have to do is text DeBakey to 37607. And without any further delay, I'm going to pass this now to our editor for the issue, Dr. Dipan J, who's going to introduce the speakers and going to give us a sense of the format that will follow today. Dipan.
Great. Thank you, Dr. Quiñones. It's a real pleasure to be here today. And I'm very glad to be joined by a number of my esteemed colleagues who made major contributions to this special issue on cardiovascular imaging. Let me just start off by introducing the speakers that we have today, which all contributed articles to this special issue of the journal. So we have Dr. Chang, who we can see on the left-hand side, who's the Associate Director for Cardiac CT. And the format for today, he's going to present an interesting cardiac CT case. We also have Dr. Mahmarian, who's the Director for Nuclear Cardiology and Cardiac CT, and he'll be providing some commentary on the case presented by Sumen. We also have Dr. Malahfji, who is the Director of the Cardiovascular MRI Research Laboratory, and he'll be presenting an interesting CMR case. We have Dr. Mouaz Al-Mallah, who's the Director of the Cardiovascular PET Program, and he's going to be presenting for us an interesting cardiovascular PET case. And then we're going to round it off with a little bit of a discussion about 3D printing, and I think that's a great application where we're taking data that's provided from imaging and using it to generate 3D printed models. And Dr. Stephen Little, who's our head of our valve clinic, will be presenting on 3D printing, and along with him is Dr. Marija Vukicevic, who is a technical expert on 3D printing. So I think we really want to get off and get started. First off, I want to thank all the panelists for joining us today, and also thank you very much for the contributions that you made to this special issue of the journal. So let's go ahead and get started. Sumen, why don't you go ahead and start us off with an interesting cardiac CT case.
Absolutely. So I should share the screen, I guess.
Yes, please.
So, are you guys see my screen? Not yet?
Yeah, we see your screen.
Okay. So, actually, thank you for inviting me this time to participate in this very interesting number, and thanks to all the co-authors for putting in a lot of work in doing this. So since we have two articles, reviews, and so I thought I will present two cases real quick. So Dr. Mahmarian can comment on these two cases. First will be a coronary case real quickly. Second will be a prosthetic valve case. So this is a 39 years old gentleman, a patient of mine, basically coming for second opinion after he went to the ER for chest pain and hypertension urgency. Blood pressure was at 200. He saw his internist, found to have hypertension, was treated. Cholesterol was, LDL was 170, was treated with diet and statin with a very good result. And he pretest likelihood of coronary disease according to the CAD consortium by European Society of Cardiology is roughly within the low probability, low to intermediate probability. He continued to have atypical symptom, and we decided to do a coronary CTA. As you can see here, his calcium score was 9 in calcium in the LAD, but he does have a huge burden of a non-calcific plaque in all 3 coronary arteries. More worrisome in the LAD, distal left main, mid LAD, some in the circumflex, quite a few more, probably more in terms of stenosis, why in the distal RCA and PDA. And this was done with our dual source CT flash mode with radiation of less than 1 millisievert between the 2 scans. All this image was acquired within less than half a second. And the CT-FFR was performed to kind of give idea the physiology of this lesion, showed that there's no likely non-hemodynamic significance in the left coronary system, and the distal RCA, PDA might be of hemodynamic significance. So he was treated again after 2 weeks intensive medical therapy. His LDL was down to about 40s. His blood pressure is well controlled. He still continue to have atypical chest pain, especially when he exercised. So we decided to do a PET. Unfortunately, this is a guy very anxious, Dr. Al-Mallah. Unfortunately, despite his best effort repeating twice, the patient would not stay still in the PET camera. But I think he was able to get some good numbers, and so reassuring. But however, up 2 weeks later, he still come back to the clinic with complaining of atypical chest pain. Sounds a little bit more anxiety, but we'll say, okay, because of the location and the significance of a huge non-calcific plaque burden, we went ahead with the exercise myocardial perfusion imaging, and he went on, he did about 12 and a half METs. After 10 minutes and a half exercise, he stopped because of his leg fatigue. No ECG changes, and the perfusion was completely normal. So I think this is a highlight, a good use of a CTA in patients who have low pretest likelihood of coronary disease. Tell us really the clinical question: does the patient has coronary disease? In this case, yes. And how bad? Well, his case was pretty bad, pretty extensive, and high risk for plaque feature. And what to do is a little bit more. I think Dr. Mahmarian could discuss, what to do with the result of CTA. In this case, I think it helps at least to exclude significant proximal disease of hemodynamic significance, and the RCA, distal RCA with abnormal FFR, we can argue if it's real or not, but basically, I think with this information, patient was able to manage medically, and 1 month later, with this result, he finally feel like he's completely asymptomatic right now, doing quite well, going back to exercise. So that's I'll highlight the use of coronary CTA for management of patient with suspected CAD. And now next, we're gonna go to example of patients with prosthetic valve dysfunction. This 81 years old patient with a surgery several years back, come here with a significant dyspnea exertion and normal EF, some aortic stenosis, aortic regurgitation by Doppler, color Doppler, and very high velocity and continuous wave Doppler, a severe prosthetic valve stenosis. And the TE was performed, as you can see here. Did not really give a clear reason why the patient had prosthetic valve obstruction. CT was performed. As you can see here, there's area of hypoattenuation between the leaflet. The density is consistent with clot. And patient, again, this is located in the aortic side of the prosthetic valve, again, consistent with the clot. This is the fancy, I guess, 4D CT rendering of the valve, showing that the decreased excursion. And so she was received heparin and with very good response. Because you can see the peak velocity went down significantly. This is after heparin and TPA. I'm sorry, she didn't respond to heparin, but responded to TPA with significant improvement of the valve gradient. Interestingly, the follow-up, you can see that the valve actually, only one of the valve recovered the excursion and the other one does not. But this time we can see clearly that actually the area of hypoattenuation was mostly located in the underside of the valve consistent with PANIS. So this is a very intriguing case of patient with mixed etiology of both prosthetic valve thrombosis and also PANIS, but the important thing with resolution of the thrombus, her symptom improved. This highlight the use of CTA for management of patient with prosthetic valve dysfunction, especially patient with obstructive prosthetic aortic valve. I think CTA is one of the most useful new technology to help us manage the patient. Thank you.
I like to emphasize what you just said. You know, we did our first TEE in 1987, and we've obviously been a big fan of TEE, but clearly in the last couple of years, we have all been converted, particularly for mechanical valves. I think the amount of detail that you can give us in terms of disc mobility and clots and panuses is way superior than what we normally get by either transthoracic or TE, with exception. There may be an occasional nice case with the TE that you show in every conference because you can see the clot. But the truth is that on a majority of patients, the CT has really become the main workhorse for assessing these patients. So great case.
Yeah, so let me just ask a couple questions. From an acquisition standpoint, if you're wanting to do CTA to look for valve mobility, can you talk maybe just a little bit on any specialized protocol that's required to do that?
Yes, I think there's two key things for prosthetic valve dysfunction. Definitely, we want to acquire the data throughout the cardiac cycle because heart is a moving organs, and we want to see how the leaflet behaves throughout the cardiac cycle, especially depending on the pathology. If it's obstructive aortic valve, you want to really look at doing systolic excursion, and if you're looking for prosthetic valve regurgitation, will be diastole for prosthetic aortic valve and obviously systole for prosthetic mitral valve. So we want to acquire retrospective gating, no dose modulation. We want to see all the details, as much details as possible. Slower the heart rate, more important because allow us to see the detail. Too fast the heart rate, more motion. And the key here is you need to deliver enough contrast around the valve to have a good study. So essentially, yes, we need probably a top of the line camera with good temporal resolution and good spatial resolution, and using retrospective gated scan mode.
So, I'd like to ask you a mundane, practical question on that first case.
Yes.
You have beautiful demonstration of the disease, the anatomic disease, and then looking for ischemia. At the end of the day, are you treating that patient as still having angina, or are you trying to reassuring him that he has non-cardiac pain?
I think both, because the location was distal left main with a large, non-calcific plaque, and he was having still non-specific, not atypical symptom. As you could see, he's a very anxious guy. He couldn't even lay still in the PET camera. So, so I think the point of, despite the CT-FFR for the LAD and left distal left main did not show significant, CT-FFR has its pitfall, and I think Dr. Mahmarian will show a very nice case of that. And having him going to exercise stress test was able, and normal perfusion was, I think, was very important to reassure him that, I think medical therapy will be appropriate because, I really hold back and not send him to the cardiac catheterization. But so far he's doing well, and, he completely changes his lifestyle. He's now in the vegan diet, he exercised. So I think seeing the CTA result of the plaque was an important wake-up call for him because he was only 39 years old and he has no family history of premature disease. I think that's one of the major advantages of CTA overall compared to stress test because you really show you the disease.
Great.
You could have a normal stress
So we
test.
move over to Dr. Mahmarian now?
Yeah.
Okay.
All
right.
John, do you have any comments on this case, or?
Well, yeah, I guess in terms of the first case, I mean, this is a 39-year-old with extensive atherosclerotic plaque. And I think in this situation, it really is best demonstrated by CTA. And I use CTA a lot in those kind of patients who have potentially are relatively young, have potentially atypical chest pain symptoms, you're not sure. And the importance here is really excluding plaque, identifying plaque, and identifying obstructive plaque if it's there. And the non-obstructive plaque obviously is incredibly important to identify because then you can impact and use lipid-lowering therapy. And, you know, there are now been about 6 to 7 serial CTA studies showing marked regression in low attenuation plaque with statin therapy versus non-statin therapy. So we can do very, very good. It's consistent with the outcome data that we know with statins in terms of regression of non-calcified atherosclerotic plaque. So in someone like this, keeping his LDL levels extremely low is very important. I also want to comment just a little bit about the issue of using perfusion imaging and the difference between that and FFRCT. Now, in this case, it turns out that both imaging and FFR were normal. And I think when you do a CT on someone such as this who's got extensive plaque but really no obvious obstructive plaque, having a normal FFRCT greater than 0.8, 0.9, which is what was the case here, can be very reassuring. I understand the reason for going on because the patient was still having symptoms. And then to have a perfusion scan normal would put him at extremely low risk in terms of short term. And so, Dr. Chang and I have published data over the last several years showing that a normal perfusion study, the warranty period is about 3 years. After that, if you have a high calcium score or if you have plaque in your coronaries, that's when you start seeing events. And so we try to impact on patients within that 3-year period to markedly reduce their risk so that they don't have events later down the line.
You have a case for us, John?
No, so I'm gonna turn it next to Maah.
Okay.
And Maah is going to present for us a CMR case for valve disease. So Maah, why don't you go ahead?
All right. Thank you, Dr. Quiñones, and thank you, Dr. Shah.
And then certainly from the audience, if there's any questions, please text those questions in to 37607.
All right. Thank you, Dr. Shah, and thank you, Dr. Quiñones. I'll be presenting on CMR in valvular heart disease and how we assess valvular regurgitation severity as well as associated myocardial remodeling. The case that I'm presenting is a gentleman who presented with decreased exercise tolerance. He lives in Louisiana. He's 57. He previously ran marathons and started having a change in his stamina as well as palpitations and atypical chest pain. And at the time of his initial evaluation, he was at New York Heart Class 2. His ECG showed sinus rhythm with frequent PVCs. And his echocardiogram at his cardiologist's office in Louisiana showed an end diastolic diameter of 8.3, an end systolic diameter of 6.1, with an LVEF of 60 to 65%. His left atrium was severely dilated, and his peak TR velocity was within normal. There was a note of posterior mitral valve prolapse with a highly eccentric gent that was directed anteriorly, and the echo was suspicious for severe MR. The patient underwent a heart catheterization that showed a mean PA pressure was slightly elevated at 28, an elevated wedge pressure with an elevated V wave, a cardiac output of 6, an ADP of 13, no coronary disease, and 4+ MR. He was later referred here for potential surgical intervention, and he underwent a cardiac MRI for further evaluation. We begin the MRI by obtaining cinace throughout the LV we begin with a short axis stack that
Mon,
covers the entire ventricle,
can you go to
and then we obtain classic standard views, 3-chamber, 2-chamber, as well as 4-chamber views.
Hey, Mon, can you go to presentation mode? We're seeing your screen.
Oh, I'm sorry.
Because we're not seeing the motion.
Go to slideshow. Tell them to go to slideshow mode.
Yeah, go to slideshow mode.
Cancel. Are you doing spotlight video? Cancel that now.
Any better?
No, we're not seeing the. We're not seeing the motion.
Cancel the spotlight. See, yeah, there you go.
There you go.
There you go.
Sorry about that. So we begin with the standard views covering the short axis of the ventricle. As you can note, the left ventricle is severely enlarged. There is significant prolapse of the posterior leaflet with high suspicion for a flail segment. If you notice this view that we obtained to look at the tricuspid valve and the pulmonic valve, as well as right ventricular free wall motion, you notice slight prolapse of the tricuspid valve as well, with no evidence of significant TR on this view, albeit the visualization of the jet is not always definitive on these views, can be highly impacted by scanning parameters. Then we move on for the mitral valve, and we obtain high resolution thin slices across the mitral valve in short axis as well as long axis views. And these allow us to try to visualize the location of the prolapsing segments, and we can scroll through them and visualize them in a higher temporal and spatial resolution than we do in the standard sequences. As you note here, there is significant prolapse of the entire posterior leaflet, but there's definitely a flail at P2 as well as P3. We add late gadolinium enhancement to all of our imaging. There's been multiple reports of myocardial scar, primarily from our group and others in histopathologic studies. And this patient did not have any evidence of LGE in these views. So we move on to volumetric analysis, and you see this ventricle is huge. The end diastolic volume is 556. The stroke volume is 317, and the ejection fraction is 57. The right ventricle is also significantly enlarged. It's at 253, and the stroke volume is 135. We do phase contrast across the aortic, the mid-ascending aorta, as well as the pulmonary artery, and we can integrate these phase contrast sequences throughout the cardiac cycle to track what the forward stroke volume is throughout the AO as well as the pulmonary artery. And those volumes were calculated to be 97 mLs in the AO and the aorta and 86 mLs in the pulmonary artery. And by this method, we can indirectly calculate what the regurgitant volume is through the mitral valve. I'll make a note as well here of the mitral regurgitation jet, which you can see here even being directed into the left atrium and the pulmonary veins, the left atrium appendage, sorry. So the mitral regurgitant volume that we calculate here is very large at 220 mLs with a fraction of 69%. We also calculate a tricuspid regurgitant volume, which is a sizable amount of 46 mLs and 36% in the way of regurgitant fraction. So the patient went to surgery. Operative findings showed myxomatous degeneration of the mitral valve, large billowing leaflets, flail segments as we discussed, and the annulus was dilated to 62 millimeters. The repair was done by Cortex Cordi, 12 of them, to the P2 and P3 segments. And then there was a cleft at P2 to P3, which was closed. A Sanjude attune ring was done, reducing the annulus size from 62 to 41 millimeters. The patient had post-operative AFib, but otherwise did okay. And his echocardiogram on day 3 showed the left ventricular end-systolic diameter to be 4.6. The EF was about 30% and the RV was depressed. No residual MR was noted. And here are his echo findings. And the patient went home to Louisiana. He was asymptomatic, he was doing well, and we brought him back for CMR a year afterwards. And as you know, as you can see, there's huge and dramatic reduction in his LV volumes. The LV function looks to be on the lower ends of normal. You can see the mitral valve repair seems to be quite successful without any evidence of significant MR, but we're going to evaluate that further. And here's the tricuspid valve. The tricuspid valve wasn't intervened upon, and he really had mild to minimal TR post-operatively. And here's our evaluation of the mitral valve in the same fashion. Volumetric analysis on the repeat MRI a year afterwards showed near total normalization of the end-diastolic volumes of the left ventricle as well as the right ventricle, with a mild reduction in LVEF, and the stroke volume was preserved. We repeat our evaluation of the forward stroke volume through the aorta as well as the pulmonary artery, and there's really trivial MR as well as mild, trivial to mild TR. Here's a conceptualization of what happens after mitral valve intervention, particularly repair. If the patient gets operated on, hopefully in a timely fashion, within the immediate post-op period, immediately the first, second day post-operatively, the LV end-diastolic volume should theoretically reduce by the amount of the mitral regurgitant volume. However, there is a slight change in the afterload immediately after the operation, where the low impedance pathway that was created by very severe MR, and this is arguable whether the afterload is always reduced in these cases with severe MR, but it seems, and there's data to support this, that the afterload in very severe MR cases is reduced. And as you immediately repair the valve, and immediately after you repair the valve, the end-systolic volume will slightly increase, yielding this ejection fraction that's reduced. However, as your LV shrinks and your diameter decreases further, we can derive from the Laplace equation that the afterload will reduce. And over time, hopefully, if you operate on the patient in a timely manner, both the end-systolic diameter and volume, as well as the end-diastolic as well as the end-systolic, should reduce, hopefully back to normal. Major questions are what time and what are the parameters that you can use to operate on the patient before it's too late and you hopefully achieve perfect reverse remodeling back to as normal state as possible. So in this patient, he had already met multiple criteria for intervention. His EF was already down, his end-systolic diameter was down, his left ventricle was huge, but he had a very good repair. He had no residual MR, he had no significant comorbidities otherwise, and he had a pretty good result. Long-term data suggests that the outcomes of repair after, the outcomes of patients after repair are still significantly improved if they get operated on in an earlier time. But it seems that in this case, at least, the patient achieved great reverse remodeling. Some questions that I've been thinking about, and I'd love to hear your opinions. How is it that MRI assessment of regurgitant volume, regurgitation parameters, does it predict reverse remodeling differently than echo does? There's already been some data, but I think we need a lot more investigations to look into this. What MRI thresholds can you use to try to achieve perfect reverse remodeling, if that's a term that I could use. And then look at the pattern of remodeling of this patient before he needed the operation. These ventricles will be thin-walled, very large, what you can consider to be a hyper-compliant ventricle, but this is not always the pattern that's visualized. Some patients will have significant hypertrophy and less dilatation than what you'd expect. And do these patterns have any implication in terms of clinical outcomes? What about patients after they get transcatheter treatments for MR? What about whether it's primary or secondary? And then the tissue characteristics and other features that we observe and perform on MRIs, do these have any association with remodeling and reverse remodeling? So a lot of work to be done in this space. Thank you.
So, man, this was a beautiful case, and certainly one of the nice things that you showed is why this patient had an MRI, because you could have argued that between the echo and the cath, there was enough knowledge of severe MR that he didn't need an MRI. But what you showed with the case is that more and more we're using today MRI also to assess function, the amount of fibrosis there may be there or not, and help us understand better those questions that you asked. So, beautiful case. We could stay here another 30 minutes discussing the case, but I think we have to move forward to another presentation. Thank you.
Yeah, Maah, that was a fantastic presentation. And I think it really shows, I mean, despite the fact that this heart was so large pre-op, what a dramatic reverse remodeling that can happen in the setting of mitral regurgitation. So I think it's a very nice case. Thank you very much. And maybe let's go ahead and move on. In the interest of time, we'll go next to Mouaz. And Mouaz is going to present for us a cardiac PET case.
Oh, I thought he was doing an echo case.
There might be an echo in there.
All right. Thanks, Dipan and Dr. Quiñones for inviting me for this session and for inviting me to contribute to this issue of the journal. And I'm going to disappoint you. I'm not going to present an echo case. I'm going to present a PET case. But I'll keep my multi-modality hat. So both cases that I'll present have some other imaging modalities with them. So the first case in this journal, in this issue, we put in 2 articles written by, with the help of a couple of our fellows. The first one looked at coronary application of cardiac PET, specifically looking at myocardial perfusion imaging, and the second one was looking at the non-coronary applications, mainly inflammation, infection, and others. So I'm going to show a couple of quick cases of both applications where we're using cardiac PET nowadays. So the first case is a 59-year-old lady who's been having intermittent chest pain symptoms. She's been hyperlipidemic, and she also had a prior CT a few years ago which showed non-obstructive disease, and now she's coming with worsening chest pain symptoms. She's been well treated. She's on Crestor and Zetia, and her LDL is 37, and her BMI is 30. So she underwent a repeat coronary CT angiography, beautiful images, very nice quality. You can see some plaque in there, although we don't read them on this. So you can see the RCA looks nice here. There is a plaque in the LAD. There is a motion artifact there. I'll prove it to you that this is artifact. So this is a zoom in on the plaque. You see the nice lumen next to it. And then if you do some rotations, that motion artifact goes away and you see the plaque in here. So because of this plaque and intermittent chest pain, and it was sent to CT-FFR, and these are the images that came back. And it's not a borderline case. This is something that dropped dramatically from 0.99 to less than 0.5. And maybe I'll ask Dr. Mahmarian to comment at this point. What would you do at this time?
Right. So this is a very interesting. This is actually my patient, and she had very atypical chest pain symptoms after having a previous CTA with non-obstructive or borderline obstructive disease. And so we got the CT, but the CT had a little bit of problems on it. I mean, there was calcium There was also some motion artifact on the images, and I assessed that maybe there was about a 30 to 40% stenosis there. So when I got back, so I decided it was probably best to do a functional test. Granted that FFRCT is more of an anatomic look rather than a functional look per se. But we came back with these values. Anything under 0.8 is considered abnormal. This was highly abnormal at less than 0.5, which was really kind of shocking to me. I expected it really to be normal. And I think just some issues about FFRCT, and one of the reasons why it might have been this value is because there was significant calcium in the coronary artery, and there was motion artifact, which can really affect the anatomic assessment in terms of flow. So because of this, and recognizing, I mean, sometimes with FFRCT, if you're between 0.7 and 0.85, you have a lot of variability in the results. But less than 0.5 is almost always considered an abnormal result and demonstrates physiologically abnormal artery. So when the anatomy doesn't fit and the patient's symptoms don't fit, and the FFR doesn't fit with what you see anatomically, then we go to something else.
All right, so the gold standard here is PET. So we moved on to PET. She had a regular pharmacological stress test. I just want to point out that despite having a BMI of 30, she received 15 millicuries at rest and stress. So the total radiation dose of this PET is 1.6, and this is because we're using a digital PET scanner, so we are able to give these lower doses. So if we have anyone from the audience who don't have a digital PET, we're not going to be able to give these amount of rubidium, and you may need more. But this one is accomplished with very low radiation, comparable to what we are achieving nowadays with CT and others. And her images are perfectly normal. You can see there is no perfusion defect. You can look at her ejection fraction. Everything looks normal. And her ejection fraction went up from 67 to 73. She also had PET myocardial blood flow assessment, and you can see here the curves are without any motion, no artifact, and her coronary flow reserve is 2.43, which is well into the normal range, and her flow increase on all three vessels almost doubled and tripled, almost 2.5 times in each vessel. So, Dr. Mahmarian, are you satisfied with that, or you need more testing?
No, I think this is wonderful, and I have to say the reason I ordered the PET study was because I didn't want another equivocal study. Okay, and with her BMI being 30, if she had had a SPECT image, I might have gotten breast attenuation, which might have then, you might have thought, could that be the LAD territory or not? And so with PET imaging, I was able to get a very high quality study. And the other important aspect of this, I was able to look at the flow reserve in each of the vascular beds and make sure that the LAD territory not only had what appeared to be normal looking perfusion on the perfusion images, but also had normal coronary flow reserve in terms of augmentation of flow during regadence stress. So based on this scan, I now feel very reassured that her symptoms are extremely atypical and that this is non-anginal chest pain.
All right, so this is what we do for coronary applications in cardiac PET. I'm going to show you quickly some non-coronary applications. This is a 50-year-old man. He woke up in the middle of the night because of chest pain. He was taken to the emergency room. As soon as he arrived in the emergency room, he developed refib arrest and he was resuscitated. They capped him and turned out to have normal coronaries, but his LV ejection fraction was 45 to 50%. And at that time, they did an MRI in the other facility, and we were able to look at the images, and you can see multiple areas of late gadolinium enhancement in non-coronary pattern, subepicardial there. You can see one in the middle here, another area here. There's also some in the papillary muscles. So this is very concerning for an inflammatory cardiomyopathy, especially when someone has a high pretest likelihood with a BFib arrest. So this patient, the question is, are these active inflammation, or this V-fibrosis could be like a scar-induced, especially with his high scar burden. The interesting thing about this patient is that when we did it, yes, there is some scar, but you can see in the same territories that we saw late gadolinium enhancement, we have significant FTG uptake. So you can see here it's corresponding to this area, and there is also some in the RV where we see some uptake in the RV and also in the basal septums, although here you see the late gadolinium enhancement and FTG uptake. So this is clearly, this patient is having an active inflammatory cardiomyopathy. He was treated by his team. He had an ICD. He was treated with high-dose steroids. And 3 months later, and this is what we are recommending, to use cardiac PET to monitor the therapy and adjust the therapeutic doses according to that. So this patient came in. He had this is his pre-therapy MRI, and now he has an ICD. So technically, you cannot compare the image quality because this is an MRI done with ICD. So you have some artifact from the device, but you can still see that there is some persistence of the late gadolinium enhancement that you see here, the one that we saw on the papillary muscle. But when we look at the cardiac path, this is his pre-therapy cardiac path, and we followed. Now the scar is still there, but there is no FTG uptake in the myocardium, and all the FTG stays in the left ventricle, and this is clearly indicating that there is no suppression and the FTG stays in the myocardium, so there is no uptake of FTG in the myocardium. And if you want to look at it, this is his pre-therapy FTG uptake, and now it's all in the myocardium and blood pool, in the blood pool without any FTG uptake in the myocardium. So this is another common use of cardiac PET, now looking at different cardiomyopathies and trying to characterize whether these are active inflammatory cardiomyopathies or old scarring from these prior involvements. And I thank you very much.
If I can ask you a question, Mouaz, this is a beautiful case.
John, if you want to add anything about the second case.
Yeah, can you
I think that it's a beautiful example of how you can track disease activity, and I think we're getting more and more information on this and how important it is. And I mean, this is such a dramatic case when you look at the uptake in the left ventricle and then you just see the blood pool and nothing else. It's really a dramatic example of how the inflammatory process was aborted.
Mouaz, can you hear me? Can you hear us?
I can't hear you.
Yeah. So one quick question. It's a beautiful case. The case speaks for itself in terms of the effect of therapy and how you were tracking it. My question, however, is, are there already studies published showing in a larger series the impact of the what is seen by PET with therapy with the outcome, prognosis, serial follow-ups, and things like that? Beyond the anecdote of one case, are there publications now showing series where you can say that if the patient doesn't show these good changes by PET, they will have a worse outcome and things like that?
Yeah, so that's a very important question. There is data to show on the baseline therapy that there is uptake, it's worse outcome. But remember, this whole field of PET inflammation imaging started less than 5 to 7 years ago. So not a single center has a huge number. So we're hoping to produce such data soon. And we are getting a lot of referrals, especially with our heart failure service and these transplant patients. And we are able to track some of these patients.
That'll be great.
Again,
yeah.
this
Super.
is still a new field, and we're learning every day.
Thank you.
Yeah, I think it's very important to recognize there's only very minimal pilot data out there looking at serial imaging in inflammatory processes with PET imaging. But it's a really a very wonderful area of investigation that I think is going to grow tremendously over the next several years.
Great.
So Mouaz, let me ask you a quick question on the first case that you showed that was a perfusion case. My understanding right now, most of the PET tracers require or don't allow you to do exercise. You have to do pharmacologic. Is there something in the future where you can actually do PET perfusion imaging coupled with exercise? Because that would be the ideal scenario.
Yeah, that's a very good question. And yes, there is something in the pipeline. It's in the second phase 3 trial, and we are participating in this trial. And maybe a pitch in to everybody who's listening. If you have somebody that you can refer to us who will be willing to undergo a SPECT PET and they're going for CAF, yes, we would like to get this study going and hopefully uh, get this approval. It's an F18 based agent called flurpiridaz. For disclosure, it's not yet FDA approved. This trial is going to hopefully get it to approval, and it will hopefully allow us to do exercise perfusion because of the longer half-life of F18 agents.
Great.
The other thing I'd like to just mention about flurpiridaz, which is very exciting, not only can you use it with exercise, but it's got better spatial resolution than rubidium does that we currently use. And it's got extremely high flows. Its uptake in the myocardium is almost linear to myocardial blood flow, which is unheard of with a radiopharmaceutical. So it has a lot of other good properties that are important.
All right, great. Okay, why don't we go ahead and we'll turn it over now to Steve. And Steve is going to present for us a 3D printing case.
Okay. Try to get my screen up here. You see my screen?
Yep, we see it.
Yeah, now we see
All
it.
right.
All right, thank you. Last but certainly not least. All right, we'll talk about patient-specific modeling for structural heart interventions and some of the applications from the great imaging that you've seen already. So this was the paper we put together for this issue of the journal. So acknowledging, of course, my co-authors, Marija Vukicevic and Stefano Filippini, and I'll take you through a few cases. So start with this simple case. This was an 80-year-old gentleman who had secondary severe TR, and these are images from his transesophageal echo. These are candidly unusually good images of the tricuspid valve. You can see he's got severe TR on the image on the right, the color Doppler, and I think we may even add some labels here. So this is a view of his tricuspid valve from the RV on the left, so the apical view looking up. From the RA on the right, you can see that arguably there might even be 4 cusps in this valve. And you can label them septal, anterior, posterior. But this is really not how a TE typically looks. This is sort of the best we've seen. But he's got severe TR. We would like to fix that for this symptomatic person. TR therapies are a frontier, and that's really the message. This is where 3D printing and sort of novel ways to look at imaging are most impactful. Multiple different devices and techniques being applied for transcatheter tricuspid therapies. The one that's probably furthest along is the application of the mitral clip in the tricuspid space, and there's a clinical trial now, and we've just begun enrolling patients looking at this particular issue. For this case, this was one of our first experiences with potentially using a tricuspid clip in a mitral clip in the tricuspid space, so we thought we would 3D print it. This is how 3D printing is done. You must start with some volumetric image. It can be a CT, an MRI, or a 3D echo, either transthoracic or TE based. With that data set, you then do a thing called image segmentation. So you really get rid of the anatomic detail that you don't want, and you focus in specifically on those elements that you do want. So it can be the whole heart, it could be a rib. 3D printing is used in orthopedics and maxillofacial surgery and all kinds of other medical fields. In the cardiac world, we've started increasingly looking at structural elements like valves in particular. And these bottom right of this slide shows a mitral apparatus. The element that's getting a lot of sort of development attention is the material selection. So it's possible to print in one specific rigid material, in multiple materials blended together. And increasingly, material scientists are discovering how to blend materials that actually behave and look like tissues. All that gets sent to a 3D printer, and then you get a product. So you can blend together multiple different materials. This stiletto heel is not what we print. We print hearts. But just to remind you, much like this periodic table, you can put together all kinds of different materials, hard, soft, multicolor, and this is where the field is really taking off in these material choices. So back to the patient. This patient had a particularly good quality 3D TE. So we took that digital data set, and this was an example of a tricuspid valve 3D printed from a TE data set, fairly rigid material, 2 colors in this case. This was a first experience with this technology. So with this in hand, we sort of played around with the clip and decided where we would put a clip. One of the challenges when you're going to put a clip, you can only put 2 of the 3 leaflets together. But sort of so informed by that 3D model, the procedure was done. There's the clip going on. There's the final result with a tissue bridge down the middle. Took over 3 hours. Still had at least moderate TR at the end of the case, but the patient lost over 30 pounds of fluid over the next few days in hospital. So a certain clinical success, although not a particularly pretty echo. Importantly is that tissues, human tissues, aren't rigid materials like that model. They have sort of deformation that we well know from deformation imaging. So one of the fields now is trying to include, both normal tissue and pathologic tissue deformation, not only deformation from devices, but how devices deform tissue. So bringing that into the field is the next effort. This is an example of a much tougher case. This was an even older gentleman who'd had a prior surgical tricuspid ring, still had significant TR, and had a more typical TE image quality. You could see it's sort of too much gain here, sort of moth-eaten. You can see a bit of the ring, but the image quality is nowhere near the same as the last case. And this one's unfortunately more representative of what a TE can typically achieve with tricuspid imaging. So in this case, we went to CT, and Dr. Chang helped us out enormously with this case. One of the nice things is when you have so much TR, the contrast hangs around forever on the right side, so you can get a nice contrast image. You can see here in the white dot, you can even see the prior surgically implanted ring. And I think in the far right here, it's kind of under my camera views of the panel, but you can see very nice definition of the entire tricuspid apparatus, leaflets, papillary muscle, annulus, and even cords. So we decided in this case, we wanted to 3D print it again. This time we would use the CT data to do so. This is one of the things we definitely want to avoid. This is a different patient. The tricuspid cords are generally not as strong or as robust as the mitral cords. A tricuspid clip looks a bit like an ice pick. And if you get into the cords, twirl around, you can get caught, tangled, and in fact, you can remove the device with a cord. And you don't really want to do this chordal biopsy. This makes the TR worse. So recognizing that chordal entanglement can be a very real concern, you want to be maximally informed before you do these procedures. So this is back to the patient. This is the CT data set. This is an example of sort of the segmentation step, identifying the right ventricle. This is a digital representation of the right ventricle from the CT. You can even see here the yellow represents the surgical ring. And then this bottom center view is the subvalvular apparatus along with the ring. Far right, we have the 3D printed right heart. And I think you can see that. And I think the next probably is the most important are these movies. And this was really the effort, is to do a tabletop tricuspid clip intervention with soft deformable tissue. So on the left image, you can see it's just a hand, and you see the tricuspid clip there. And you're sort of closing it. So the leaflets are printed soft and deformable, where you can actually achieve a coaptation. And the most important image is the one on the right. This is viewed from the 3D printed RV apex. The papillary muscles are blue, and you can see that there's a concern about chordal entanglement. So as this plays, the device is being manipulated, and you can see how it could easily interact with those cords. So you don't have a lot of freedom of motion and where that device can go. So maximally informed by a 3D printed model, you can take that data and actually you do the intervention on the model. This is a little trip we do in the cath lab. We'll actually do a cone beam CT or a rapid sequence CT. You might argue that's not a real CT, but because the model is not moving, it behaves for us. And we get some very nice imaging that looks like this. So this is now the clip deployed within that model. And by adjusting thresholding, you can get a very good sense of where the clip actually lands in relation to all of the anatomic elements. And particularly on the image on the right, you can see that we landed sort of on the model, of course, this is where we needed to go. Not a lot of freedom of motion of other places. This is the ideal landing zone. That's exactly where you need to be to avoid the cords and avoid all sorts of trouble. So with that knowledge in place and that practice, the entire implant team can gather around the model and this derived video and know exactly what they're going to do in this particular patient-specific case. So with that background, the case was then done. Clip was put exactly where the modeling suggested it should go. There was some residual TR, but not the torrential TR we started with, and we had a very, very good clinical response. So this is a snapshot from the guidelines on how to quantitate TR. The point of this is because of the ability to interact in these very severe scenarios, now we're starting to recognize, or some are advocating for these other categorizations of massive and torrential TR, and the clinical question of if you move from massive to severe, or ideally to less than severe, what is the mortality and quality of life benefit? So these new technologies are allowing us to start to answer these clinical questions. So the patient-specific modeling, this is a bit future-looking. Already today, you can do modeling for size, modeling for effect digitally. When you physically print a model or 3D print it, you can start to model for interaction. The nearer term is we're going to be modeling for deformation and ultimately modeling for flow. So procedures with uncertain outcomes should be maximally planned. CT clearly provides unparalleled level of anatomic detail, especially for static structures. Occasionally you'll get that with a 3D echo, but not often. Patient-specific modeling is possible. You can do digital or physical modeling. And it just really introduced the notion that there is bidirectional modeling that recognizes that a tissue can deform a device and a device can also deform a tissue. I'll stop there to allow some questions. Thanks very much.
So Steve, that's a fabulous presentation. One question, when you're practicing with the model to know where the landing zone is, you have it in your hand and you can very nicely put it there and okay, this is good or bad. Now you're in the cath lab. You don't have that luxury. In the cath lab now you have fluoroscopy, TE. How do you transmit that information in the cath lab to know exactly how to get to that landing zone? That's not one question. The other one is, are there tricks that could be used by doing some fusion imaging between the model and the patient and fusing CT or whatever that will aid you in the cath lab to hit that landing zone that you want to hit?
You can actually, we've done a little bit of that. You can sort of back calculate. You can print the model. You can do the intervention on the model. You can then co-register your intervention on the model to the actual patient's CT, which gives you, all of the bones and the structure. And then from that, you can calculate catheterization angles and fluoroscopy angles to sort of see things. So that is certainly possible. That's a lot of the software work from various vendors is doing that now. You do the intervention either digitally or physically, and then you optimize in that sense all of the angles you need in the cath lab. And then by co-registering back to the clinical study, you can sort of create those models, assuming that the patient lies in roughly the same position. So you get very close. The fine tuning you still have to do with live imaging, but a lot of the procedural setup you can do now based on CT.
That's really, really fantastic.
And let me just ask a quick question to Marija, because obviously you're the one taking these 3D data sets and segmenting them and to be able to get the proper, to be able to do the 3D printing. So what's the amount of time that's required, and how between, let's say, doing a CT versus doing an echo, 3D echo, or 3D CMR?
So doing the echo is really quick. It can be like from 20 minutes to maybe an hour, depends on the quality of the imaging of the echo. Using the CT imaging is a little bit longer, but it provides also the more complete data in a way, because we can isolate the ventricle, we can extract the atrium and the aorta and the chordae. So for the CT-based modeling, we do need maybe 3 to 4 hours, but depends, of course, of the complexity of the model itself and what we want to achieve.
Okay, great. Okay.
Well, the hour goes fast when you are having fun. So I think we are right about time to thank everybody, especially all of the faculty that has joined us. Fantastic presentation. All the cases were great. And we want to thank all of you who have been watching us from your home or your offices. And this does remain in our archive. So if you didn't have a chance to watch it live, you can come back and watch it again.
Great.
Good evening.
Good evening, everybody.
Thank you.
Thank you.
Thanks, guys.
Thank you, guys.
And Marija,
Thank you.
very nice job.
Great job.
Thank you.
All right.